So oftentimes when a patient presents to clinic, I'm asked the question, why do I have pain? Why do I have this particular type of pain that's emanating from my joint? Now, that might seem like an incredibly simple question, but our understanding of it is really evolving. And the scientific discoveries that have happened, particularly over the last 5 to 10 years, have led to our rapid evolution of knowledge as it relates to the sources of pain and the types of pain. Today, we're going to have a conversation very much around the biological part of the biopsychosocial model. So that biopsychosocial model takes into account the biology, the so the psychological aspects here. So that's the depression, stress, anxiety, catastrophizing, and the social elements there. So that's where it's really important we take into account a person's occupation, their socioeconomic circumstances, their income, and things of that nature, which all play a really important role in the appreciation of pain and the disability that comes from osteoarthritis. So again, today we're going to dig very much into the biological component of that. So what's actually happening specifically at the joint level. And in addition, talk about the different types of pain that can occur in the context of osteoarthritis. It's a very complicated topic, one that I hope you garner a lot from. But again, if you want to dig further into this content area, we've had a couple of previous episodes where we've talked about pain and osteoarthritis that included conversations with Anne-Marie Malfay and also with Jason McDougall, if you do want to dig further into the origins of pain and osteoarthritis. So again, something that is incredibly complex, something that we're still continuing to learn about. And whilst it might seem simple, osteoarthritis pain is extraordinarily complex. And we've really privileged to have today a wonderful guest, Nidhi Sofat, who's a professor of rheumatology at St George's at the University of London. And her research focuses on this area of the causes of pain and inflammation in musculoskeletal diseases. And she's got a very translational approach to that, meaning she takes research from the laboratory bench to the clinical bedside and conducted a lot of trials in that space. Hello, Nidhi. Welcome to the show.
Hello, David, and thank you for inviting me. It's a pleasure to be here.
Oh, it's our pleasure. And I think you're going to share a lot of insights and knowledge. So really looking forward to that. But before we get into the main content of the day, just hoping that you might be able to share with the listeners a little bit more about your background and what a typical day looks like.
Sure. So I'm a consultant rheumatologist for half of my time. That means that I see patients in my rheumatology clinic. And that's quite a broad range of patients with rheumatic diseases, not only osteoarthritis, but also rheumatoid arthritis and other autoimmune conditions. And because I work in London, we have a very diverse, multicultural population, and I get to see people from all walks of life with the conditions that we treat. As part of that, I also do clinical trials, predominantly in osteoarthritis, but also some trials focused around pain and pain mechanisms generally in rheumatic diseases. Then the other half of my job, when I'm not being a doctor, is doing research. And I have a translational research lab here at St George's. And that means that we look at tissue and samples from patients, predominantly with osteoarthritis, and relate that to some of their clinical features and try and get a deeper understanding of what's going on in the disease process.
Sounds fascinating, and I'm sure provides plenty of opportunity for cross-fertilization, both from the research world to the clinic, but also in the reverse direction from the work that you're doing in the clinic back to the lab and informing that.
Yeah, absolutely. And I think my work has really been enabled by working in a multidisciplinary team. We have basic scientists who are very interested in the molecular mechanisms of disease, but we also work with imaging scientists, radiologists, and clinical trialists. And I think that sort of cross-fertilization of ideas really has helped us think about how we can develop some new approaches to try and understand osteoarthritis pathophysiology.
Yeah, fantastic. And hopefully we'll get into a little bit more detail on that later. But before we go there, when you're not at work, both with the two hats where you sound like you split 50-50 most of the time, what do you enjoy doing?
I like to switch off when I'm not at work, and a lot of that is involved around things I do with my family. So I love cooking. and trying out new recipes on my husband and my two boys. And they are good, testers. And they'll tell me straight away whether it's good or not. So most recently, I've been doing homemade Neapolitan pizzas, which have gone down quite well.
Fantastic.
In addition to, from my Indian heritage, I love doing Indian cooking. So that's great. And obviously, because I work very much in a clinical and scientific environment, I try and get outdoors when I've got some free time. So I live really close to a park here called Richmond Park, which is great for walking around and doing some nature walks. Keeping fit, I love doing yoga and maybe some more high impact exercise as well in the gym, because I think we should really talk to our patients about exercise in a way that we can relate to. So I often talk about yoga moves with my patients and what they can do and can't do.
Yeah, I think you've got to live the talk, right? It's very easy to convince people if you're actually practicing it yourself. And so, oftentimes when I'm particularly talking to people about hip osteoarthritis and people who do yoga and they find the internal rotation very difficult, I talk to them about pigeon pose. And then, they look at me and say, where does that come from?
Yeah.
But no, I think it's really helpful to actually have a little bit of practical experience living that yourself. Now, for the boys, it's always good to have people who are very honest with you. Are they very honest in their appraisal of your cooking, Nidhi?
Absolutely. I like my chili, and they might not be able to tolerate it as well as I do. So yeah, they'll be very clear. They are the harshest critics, but this is a learning process. So I'd like to think that I'm improving every time.
Wonderful. No, it sounds like a lot of great interests. Now, Nidhi, if you had to describe yourself in 5 words, what would they be?
This is a challenge, but I'll have a go. I would say I'm very curious, and that's generally in life, both in work and not at work. I'm also quite a creative person, so interested in art, but also creativity within work and how we can develop techniques to answer questions, particularly, in the field that we work in. I'd say I'm quite determined. So if I set some goals, I try and achieve them. I'm quite optimistic as well, and I think you have to be as a clinician and a scientist. And I'd like to think I'm caring, and people have told me that I'm caring, so that's nice to hear.
They're all tremendous qualities, both as it comes to being a clinician, but also a researcher. This is probably a little bit of an unfair question, but it intrigues me. Which of the qualities do you think are the ones that are most helpful for you as a researcher?
I would say the two main ones for me have been creativity, because you've got to come up with the ideas. And a lot of that comes from reading. I'm always telling my students and fellows to read as much as you can, read the literature and really know it, and try and keep up to date with it, because that's what brings in new ideas. And not necessarily reading from your own field, also reading from other fields in science and in clinical medicine. And I think the other quality would be determination, because, as you know, the road in research and science is a long road. And from the inception of an idea to actually realizing it and proving it can take years and years. And you've got to see that, and be realistic as well.
Yeah, no, completely agree. It's great advice. And, particularly the latter point, I do think qualities like patience and resilience are often underestimated here. And as you just suggested, sometimes from the inception of an idea, particularly for things like clinical trials, to the point where you actually generate results and publish it, it could be up to a decade. And so you have to be very patient, but also resilient in the face of oftentimes adversities and barriers and rejections and other things, which I think that's where the optimism also helps.
Absolutely.
Anyway, all right. Now, the main focus of today really is talking to you and getting your insights a little bit about the origins of pain and osteoarthritis. And this is on the back of a publication which twigged me to reach out to you, which is really about pain stratification in musculoskeletal conditions and the implications that might have for clinical practice. I think there's a lot of opportunity for us to learn from the insights both in that paper, but also the other work that you're doing. And so just as a very soft question to start, what's the source of pain in osteoarthritis? It's a big question, but it's hopefully a question to get started.
Yeah. As you rightly point out, it's a big question, and it might seem to many as quite a simple question that we should know the answer to. But I think it's a lot more complicated. And I think we're beginning to discover more and more about the mechanisms of pain in osteoarthritis. So when I was at medical school, I trained at UCL, and I remember being given lectures about osteoarthritis and explanations around cartilage being the main region of primary damage in osteoarthritis. And we certainly accept that. But I remember thinking, even at that time, being taught at the same time that cartilage in physiology is avascular, so it has no blood supply, and it's aneural, so it has no nerve supply. So I was intrigued as to, how can it be that this primary area that is damaged doesn't have a nerve or blood supply, but is then giving rise to pain and reduced range of movement in many of the patients that we see. So I guess my interest in osteoarthritis rose from that initial encounter with understanding the pathophysiology. And then if we think about the other structures in the joint, the synovium we know is really important. It produces a lot of the nutrients that then are released and go into the synovial fluid, which then diffuse into the cartilage. That is clearly a source of keeping the cartilage physiologically working and integrated. But we also know that the synovium has a really rich nerve and blood supply. And it's great to see now more and more studies that are demonstrating that synovitis and activation of inflammatory processes in the synovium are contributing to pain in osteoarthritis. So that's certainly a really important recognition, I think, that has come about more, I would say, really in recent years rather than the original descriptions of osteoarthritis. And then I would say, because osteoarthritis we know is a disease of the whole joint, the other big structure, which perhaps, has been neglected in the past, is the bone and the subchondral bone. And I've become very interested in my research group in looking at the subchondral bone. And some of the initial observations were epidemiological studies, which showed that structures in the bone, which are called bone marrow lesions, often we abbreviate that to BMLs, are associated with pain from the epidemiological literature. So when I started reviewing that and trying to find out what is it within BMLs that might be contributing to pain, there was quite a lot of literature regarding imaging, and as you know, various scoring systems have been developed, mainly using MRI, magnetic resonance imaging, which show these BMLs as high signal on a particular version of MRI called the T2 fat suppression. And that's just a protocol that patients can have, and when they have their MRI scan, we can detect these BMLs. So we felt that, bone could be quite an important source of pain because we know it's richly innervated and it has an excellent blood supply. And we know that from the clinic because when people fracture, they break a bone, that is a severely painful process. So we wanted to extend the knowledge to what is already known. And we looked quite closely at the paper by Talanovic et al. In 2008. And they looked in HIP-OA and looked to correlate X-ray symptoms, MRI, and tissue. And on that study found some of the changes that we went on to see as well. And that included fibrosis, cysts, which we see on MRI in BMLs, but also they suggested that there were areas of microfracture. And when we looked at the histology from that paper, it looked like there were new blood vessels, certainly in those areas of microfracture, which would fit with the story that, blood vessels and nerves travel together in a bundle called a neurovascular bundle. And if populations of those areas are increased within BMLs, that could certainly be a really important source of pain. So we then moved our attention to look at knee osteoarthritis because knee OA, as you know, is one of the most common forms of osteoarthritis, and there was very little work done on BML gene and protein and cell changes. So that was the subject of our first paper in this area in 2017. And we had a PhD student who painstakingly collected tissue from patients who were having routine joint replacement surgery for their osteoarthritis. So they were quite severe cases, obviously, because they were presenting for knee replacement. And together with the surgeons, we were able to ensure that all of these patients had an MRI scan within 6 weeks of their surgery. So they wouldn't normally get an MRI scan, but we were able to do it as part of the study. And patients were very willing to have it because they were interested to know what was going on in their tissue. And we found using the MOAC score, which you know well, the MRI knee osteoarthritis score, that these patients had definite changes in their joint. They had cartilage degradation, they had synovitis, and they had bone marrow lesions. And we were independently able to show through the radiologists who scored those scans that these were the particular areas where the BMLs were found. We then took those scans to the surgeon at the time of surgery and were able to harvest the tissue containing the bone marrow lesions. So we could then treat it and extract cells from that tissue so we could look at the gene profile. So that led to the first microarray gene study, looking at the whole gene expression, which we sometimes call the transcriptome of the tissue. And that was really exciting work because we were able to compare it with people who didn't have bone marrow lesions. So you might ask, well, how did you get the bone from people who are normal? Because that may be quite a challenge. And we harvested it from people who were perhaps in road traffic accidents or who needed amputations for injuries, and their bone was normal and intact, and they didn't have any osteoarthritis or other pathology in their bone. So we were able to use this microarray technique and apply our test group, which was the OA BML group from the knee, and then the control comparator group who didn't have OA. And what we found was that there were over 200 genes that were upregulated. So they were increased in this bone marrow lesion tissue compared to healthy controls. And obviously that's a lot of genes. So we needed to do some more sort of pathway analysis. And there are various databases where you can look at this and feed in the genes that you found and look at which pathways are activated. And what I would say is that we found 4 main pathway groups that we were able to identify. The first group we describe as the neuronal pathways. So those included genes like stathmin-2 and thrombospondin-4. And those genes we know are involved in laying down the nervous system during development and also involved in new nerve formation and also pain sensitization, particularly thrombospondin-4. So that was really exciting because it was suggesting that perhaps actually new nerves are being formed and developing connections within bone marrow lesions. And we don't know why this is. It could be resurgence of what happens during development, during embryology, or it might be happening as a response to the damage that has occurred. Because often we see the bone marrow lesions quite directly beneath the areas of cartilage damage, so in the subchondral bone. So that was really interesting, and we were able to validate that by looking for new nerves in the tissue, and we published that about 2 years ago with a scoring system, which I'll come to in a moment. But we were able to use this stain, it's called PGP 9.5, and it's a very specific stain for nerves, and we were able to see it very clearly that nerve expression was increased in the bone marrow lesions. So that was really exciting. And it often seemed to follow where the blood vessels were. And that brings me to the next group of genes that we found, and those were linked to angiogenesis or new blood vessel formation. And one of the most prominent mediators we found was VEGF, vascular endothelial growth factor. We also found mediators like NF-kappa B, which is a molecule that's involved in a lot of inflammatory processes, including angiogenesis. So that was really exciting. Then the third group that we found was cartilage genes, which you would say, okay, this is osteoarthritis, you should find cartilage genes. But it was interesting that we found it in the bone marrow lesion tissue. And when we then also stained the tissue for cartilage, we found that there was cartilage staining using this stain called safranin O. So we think what is happening is that the tissue is trying to repair itself and it's switching on genes that would normally be expressed during development. So those include genes like SOX9, MMP13, chondroadherin, which are all genes that we found. And we think that it's trying to repair, but perhaps it's frustrated repair because it's happening perhaps in the wrong place in the subchondral bone. So we're very interested in looking at that, and there's further work going on in our group about that. And then the last but not least group of genes that we've been looking at include pro-inflammatory pathway genes. So that's not only NF-kappa B, which I've mentioned already, but also chemokine genes and cytokine signaling genes. And I think that's also really exciting because traditionally osteoarthritis has been considered a non-inflammatory condition, particularly by rheumatologists who manage people with very severe inflammatory disorders like rheumatoid arthritis. But we clearly see it there. And so that makes us think about, could there be local treatment targets for inflammation? The other thing I would just say is that obviously those are the 4 groups we found, but we found a lot of bone turnover genes as well. And I think that's important, showing that there is increased bone turnover, for example, with catinin, which is a target that many drug companies are looking at in osteoarthritis treatments, and rank ligand, which there are potential drugs. So I think that's my kind of summary of what we found in the bone marrow lesion tissue. We have followed on the work from the gene analysis, looking at the histology, which is a more kind of traditional method for looking at changes. And if I perhaps compare our work with the cancer field is way advanced to what we're doing. So they're very good at taking a biopsy of tissue, defining what its gene signature is, defining what the histology looks like, and then potentially relating that to treatment. And I think that's a potentially really attractive paradigm that we could think about in osteoarthritis, but also being aware of the different tissue components and compartments that are involved. So leading on from that, we've developed the osteoarthritis bone score, the OABS, which has really defined 7 changes in the histology that we see within the bone marrow lesions. And that, again, we compared using non-bone marrow lesion tissue in the same patient, but also validated it in other data sets from biobanks that we got, particularly with collaborators from the University of Nottingham. So the main changes that we found in the histology were the cysts that we also see in MRI. So that was nice to see it in both ways of assessing. We also saw fibrosis, which is obviously a recognized response to injury in different tissues of the body. We also saw breaching of the tide mark. So this is the barrier in between the cartilage and the bone. And usually it's got a very nice, distinct boundary. But what we found is that it was often breached and invaded by new blood vessels within that area of the BML. So that was a characteristic finding. We also saw new blood vessels or increased angiogenesis. And here I'm talking about new blood vessels within the subchondral bone compartment. And then we also saw, again, within the subchondral bone, new cartilage, which we stain using this stain called safranin O. And we also saw thickening of the trabeculae within the bone. So the bone is a structure which has a framework, which is made of trabecular or mineral type tissue, which gives bone its strength. And within those trabeculae, there are then fat cells, there's bone marrow, there's stem cells. And what we found is that trabecular part of the bone was thickened. It was even thicker than it would normally be. And within those areas, we also saw inflammatory cells like macrophages and neutrophils. So those are the 7 changes that we found. And we are now trying to identify whether other parts of the body which are affected by osteoarthritis have the same changes. And is it just the knee or other changes as well? So very exciting project we're doing is looking at hand OA, which, as you know, anatomically is a really different sort of joint. And we've been looking in base of thumb osteoarthritis, CMC joint. And we work with some hand surgeons here who do trapeziectomy surgery in very advanced cases, which obviously in patients where medical management or steroid injections haven't worked, that's an option. And we're finding the same 7 changes that we've seen in the OABS. So that's really exciting because it's suggesting that there's a final common pathway of BMLs.
Fantastic. That's a great set of work and a great description of the tremendous progress that you're making there. Nidhi, I just wonder if you can comment, because you did this in a wonderful way in the paper itself, on the different types of pain that occur in osteoarthritis.
Yeah. So we were really interested to try and think about pain stratification, because I think as clinicians, we get a feel of what sort of pain is going on in our patients. And I think it can be quite challenging for patients to understand what is driving their pain, and it might be different at different stages of their disease. So in the paper, we talk about the 4 main categories of pain that we recognize, particularly in rheumatic diseases. And osteoarthritis is a prime example of this. So the first sort of group is the nociceptive pain group. And nociceptive pain in sort of the medical literature is described as damage to non-neural tissue, so tissue which is not nerves. And that includes joint tissue, but also visceral tissue, for example, the gut and also the skin. And if someone has a sunburn, nociceptive pathways are activated. So that's a really important pathway that we recognize. There's also inflammatory pain. We've studied inflammatory pain for many years, for a long time, and we know that different mediators get released during inflammatory pain. And those include things like prostaglandins and leukotrienes. So those are inflammatory mediators. And there's been a lot of research done in that area. And we know that drugs such as non-steroidal anti-inflammatory drugs, NSAIDs, definitely target those pathways and suppress those mediators being released. So that explains perhaps why people who have flare-ups in their osteoarthritis might take anti-inflammatories for several days or several weeks, and then that leads to a suppression of their inflammatory pain. But I think what's been more interesting to investigate more recently is, what about the patients who have taken anti-inflammatories or have had steroid injections, but continue to experience pain at quite a sustained and a high level? And we're seeing more and more evidence that they might be demonstrating features of nociplastic pain. So nociplastic pain is a sort of a fairly new term that has really been described and discussed more recently in the last few years in the literature. And it's the concept that a patient might have altered or changed nociception, even when you can't see definite tissue damage or you can't see threatened tissue damage. So I think that it's taken quite a while to ensure that people understand what that means and how is it different and how can we measure it. So I think measuring pain is a really important part of this, because traditionally we've used questionnaires, we've asked patients, how much pain are you in? You could argue that actually we're not that great at measuring pain, because often our pain scales are 0 to 10, 0 to 100, they're quite linear, and actually people have all kinds of experiences of pain. So it might be episodic, it might be occurring in different ways, so that people might be experiencing pins and needles, numbness, radiation to different areas. And you could group a lot of those features into this kind of heading or theme of nociplastic pain. And in the paper, we describe how various different measures have been developed to try and detect this. And that includes questionnaire type measures. So I am a great supporter of some of these questionnaires because I think they're easy to do in the clinic. And there's more and more data coming out showing that they do tell us about nociplastic pain. The sort of questionnaires I use in my clinic would include the Pain Detect questionnaire, the Neuropathic Pain questionnaire, and often it's something that a patient can fill in before they come in and see us in the clinic. And we can just be highlighted about what are the features of pain that they're experiencing. What I find, particularly in my patients with knee and hand OA, is that they are experiencing pins and needles. They are experiencing episodic bursts of pain, which often occur at rest, sometimes after exercise. They also get radiation of symptoms. If in the knee, it can go down to the foot, up to the hip. And these are all really important features, I think, that we need to think about and recognize early. Because I think if we recognize it and are able to help patients recognize that this is part of their osteoarthritis, we can then start thinking about what potential interventions could help them. And there is obviously data coming out from other rheumatic diseases, such as fibromyalgia, that nociplastic pain can be helped by interventions such as exercise, CBT, planning activities through the day so that you can really spread the load literally of your joints, but also the levels of pain so that you're not aggravating pain episodes. So I think that's really important for us to recognize as clinicians, but also to then explain and discuss with our patients. Because I get a lot of questions from patients about why their pain is occurring in particular ways at particular times.
That's superb, Nidhi. Just to, I guess, briefly expand on, you started touching upon it with at least some of the questionnaires that theoretically we might be able to use to ascertain these different types of pain. Sounds like there are obviously limitations as it relates to classifying these different types of pain using the tools that we currently have. Any tips for people out there who might think that they have, either a nociceptive, nociplastic, neuropathic, or inflammatory pain that might help to characterize subtle differences between those types of pain that could theoretically help to disentangle that complexity?
Yeah, absolutely. So I think from the questionnaire level side, what I tend to do now routinely in my osteoarthritis clinic is give patients the questionnaires literally in the waiting room before they come and see me. And I would give them variations of a numerical rating scale, whichever one people have available to them in the clinic. WOMAC, as you know, is more of a research tool, but it can also be helpful, I find, in the clinic, particularly after you've used a certain intervention. And then I would tend to use one of the nociplastic pain questionnaires. And as I'm already alluded to, I tend to use Pain Detect because we've tested it quite broadly in our patient population. They seem to understand it. It's quite visual. The patient can mark on the mannequin where they're experiencing their burning sensation, their pins and needles, their radiation. And it's also got a numerical score. So if we plan an intervention, be that exercise, CBT, lifestyle changes, we can then measure it again after that intervention and discuss with the patient what happened. So that's what I found quite useful in the clinic. I mean, I haven't talked very much about other ways of quantifying pain, such as quantitative sensory testing or QST, which we use a lot on the research side. And it gives us more information about nociplastic pain, I would say, particularly around measuring peripheral sensitization and central sensitization. But I think practically in the clinic, often our clinics are busy. We only have a limited amount of time with our patients. And so I think the questionnaire sort of model is very helpful.
Yeah. And Nidhi, I'm mindful that I'm going to digress into what is pretty much an evidence-free zone as far as osteoarthritis is concerned. But let's work on the assumption that you've identified that someone has nociplastic pain and it's their predominant source of symptoms, or they have neuropathic pain and that's the predominant source of the symptoms, as opposed to the nociceptive pain that you're describing. How does that modify the way you manage these people in the clinic? And again, I appreciate there's no trials here, but what do you do differently?
Yeah, I mean, I obviously need to start, as you said, with the caveat, there is no clinical trial evidence here. But I would say that I try and identify these patients early because they are definitely a different subset of OA patients. They don't follow the kind of linear model that many of us have been taught that inflammation, damage leads to pain, because often they might have already been treated with NSAIDs, they might have already had intra-articular steroid injection, but they'll often come to someone like myself as a second opinion. They've got a lot of pain. And that's one feature I tend to find in this subgroup of patients, that they often have quite chronic, widespread pain as well. So the question is, and as you say, the data is not there yet, is osteoarthritis being manifest in patients who have underlying chronic widespread pain in this subgroup? And really, they're being labeled as having osteoarthritis, but they actually have a broader pain experience. And we know, we haven't really talked much about this, but the biopsychosocial model of pain feeds into this as well. And, you know, their environmental, social, anxiety, depression, all of these factors impact on pain. So I think if I was beginning to see that in the clinic, that there are these sort of flags coming up of these pain characteristics, I would probably delve deeper into investigating a bit more about anxiety, depression. I often find some of these patients have quite strong family history as well of chronic widespread pain, fibromyalgia. And then we try and work within the guidelines we have. So we have guidelines for management of primary pain, and that not only includes lifestyle, so exercise, activity, weight loss, diet, but also pharmacological, if, you know, that's something that the patient needs. And often by the time they come to us, they are in real need of help. And sometimes I find that pharmacological interventions using some of the centrally acting analgesics, for example, gabapentinoids like pregabalin or duloxetine, can really help patients get over that initial period of helplessness and frustration and really severe symptoms which they can't overcome. And often it's trying to work with the patient to help them overcome those symptoms and then go through stepwise how they can then look at long-term management. And that's one thing I really try and put across, that, you know, osteoarthritis is something that happens over several decades. And it's trying to get patients into a pattern of behavior that's going to help them in the long term.
Yeah, no, I think the thing that's often underappreciated is the chronicity feeds on itself. And the longer you leave this and the less proactive you are about managing it, the more complicated this can become. So I think early identification, as you suggested, is key, but then the overlaps that this might have with other chronic widespread pain problems is really very poignant, particularly in later stages of disease. Now, Nidhi, your comments about what we can currently use are really helpful, but as I think you pointed out, there are huge limitations with the way we currently manage these sorts of problems. What promising things do you see on the horizon as far as therapies are concerned?
So from what we know, particularly about the pathways we've just talked about that get activated in the synovium and the cartilage and the bone, I think potentially having a drug target that could inhibit those processes at the joint level would be really attractive. I mean, there is some promising data with therapeutics from phase 1 and phase 2 trials. I was just looking at the angiopoietin-like 3 derivative, LNA043, which is looking very interesting in terms of trying to encourage cartilage regeneration and promoting the stem cells using a drug intervention. So I think that sort of approach might be very attractive for a long chronic disease like osteoarthritis. And there are some other agents, for example, pentazan polysulfate, which is an NF-kappa B inhibitor, which has just completed phase 2 trials, which also looks really promising because, as we just discussed, NF-kappa B is activated in all of the joint compartments we discussed. So targeting molecules such as that might be very attractive. But obviously, these are quite early studies, phase 1 and 2, and I think we'll learn more as hopefully they go into phase 3. But the sort of holy grail, you might call it, of trying to find a disease-modifying osteoarthritis drug, I think is still something that really needs to be addressed because, you know, we're getting more and more people with osteoarthritis. And I think we're recognizing people with earlier disease now as well because they're coming with symptoms.
Superb, superb. There's a lot of great products that are in late stage therapeutic development now that both target pain predominantly, so the symptom modifying drugs, and others that are focusing on the disease modification space, Nidhi, as you just suggested. So Nidhi, just for the general audience, and hopefully something that they can be proactive with, but is there any one piece of advice, knowledge, or wisdom that you'd like to share with our community?
I would say to all the patients, and my mum is a patient, and so is my husband, he's got knee osteoarthritis, is keep moving, really look at your lifestyle. And even if it's small changes that you can make, for example, with exercise and activity, really try and stick to them once you've started making them, because they will pay dividends if you keep going with it. And lifestyle includes diet and weight loss as well as exercise. That would be my main message.
Wonderful advice, and hopefully your sagely advice gets imparted both to your mother and the husband, and they follow it astutely. But Nidhi, thank you so much for sharing, firstly, the wonderful work that you're doing in your research laboratory and the knowledge that you imparted about how we might use that in clinical practice and obviously for both current and future therapies. And again, really appreciative of your time and insights. So thank you so much.
Thank you. It's been a pleasure.
So today we've spoken about the biological sources of pain in the context of osteoarthritis, and in particular, why the lining of the joint, the synovium, might play a role here, why the bone itself might play a really important role here, and the changes that occur in both those tissues in the context of osteoarthritis that might be important as far as generating pain. We also spoke about those complex topics of the types of pain in osteoarthritis. We obviously didn't touch upon a whole lot of different constructs as it relates to the severity of pain, the frequency, or its character, but really spoke about those broad types of pain of nociceptive, nociplastic, inflammatory, and neuropathic. In the context of osteoarthritis, all of these can occur, and they often co-occur. The most frequent of which is obviously the nociceptive piece, but neuropathic, nociplastic, and inflammatory pain can also occur. And increasing knowledge is seeing increasing frequency of all of those different types of pain. There are different ways that this can be assessed. There are different therapies that can be used in the context of this in clinical practice, mindful of the fact that some of this is really evolving knowledge. And there's lots of clinical trials that are working on evolving our knowledge as it relates to this. So continue to watch this space. We'll provide a link to Nidhi's paper in the show notes if you want to dig further into that particular topic. Hopefully you found today's topic interesting and engaging and informative. And thank you for your continued support of the Joint Action Podcast. And between now and when we next have an opportunity to converse, please do take care of yourself.
Thanks for listening to Joint Action with David Hunter. If you like our show and want to know more, visit www.jointaction.info. If you have any questions, you can email us at hello@jointaction.info and follow us on Twitter @jointactionorg. This podcast was hosted by David Hunter, edited by Vicky Duong, music produced by Jordan Hunter. The information posted on this podcast is not intended to diagnose, treat, cure, or prevent disease. Anyone seeking medical advice should consult a health professional.